Okay, we'll get started. First exam, everyone did very, very well. So now we're going to move on to all the other neural diseases. A lot of you guys can say, what about treatment? What about treatment? Well, today for stroke, there's only one treatment for stroke, it's TPA. Otherwise, you don't do anything, it's all symptom management. So, but we are going to go through when do you give TPA, what are the contraindications, and relative contraindications, and so forth. So this is a good one for your test for today. Yeah, we can do that one. Okay, so we're talking about strokes, the different types of strokes, how do we give treatment for it, the definitions of blood supply, and all that fun stuff. So brain attack, again, trouble walking, weakness on one side, trouble seeing, trouble speaking. These are signs and symptoms of an impending stroke. Make sure you think fast. Tell Facebook you're having a stroke. Lots of prayers, lavender oil, talking about. Yeah, this is the real one for fast. Facial weakness, arm weakness, speech problems, and time. Time is brain, so you have to have there's a time frame. You have to know when was their last normal in order to give those TPA, the clot-busting drugs. So here's a video of a patient who was on a talk show, and during the talk show, developed a stroke, and you'll see what happens. Okay, so we'll skip. You can watch on your own. You'll see it. Okay, very important. Last known well. Yes. Yes, you're right. It's a different system. Okay, so last known normal is the important part. If the patient can't tell you their last normal, you have to ask family, friends, whoever was there, when was the last time the patient was normal? If they wake up with a stroke and the last time anyone saw them being normal was 6 p.m. the day before, 6 p.m. was the last time they were normal. You know, because the TPA window is only 3 hours. If you're outside of 3 hours, you can't do it. So cerebral infarction is just like a myocardial infarction, death of brain tissue due to impaired perfusion. It could be like an MI or global hypoperfusion where there's no blood supply to the brain at all, causing a global ischemia, making you pass out and so forth. Obviously, vascular occlusions, the big one. You can have thrombotic or embolic, and we'll go through those in a little bit. So cerebral ischemia, just like in cardiology, ischemia means it's a transient condition. It can get better just due to impaired perfusion. A TIA is a transient ischemic attack. It's a brief episode caused by a focal brain or retinal ischemia. Usually these patients will have these symptoms less than an hour. Usually those neural deficits take about 30 minutes and they go away. We'll get to TIAs in a little bit, but the big problem with TIAs, if they have one, the likelihood of them having a massive stroke goes up. So you still have to do all the patient education, patient management for these people to make sure that they're okay. No evidence of acute infarct. So you can do a CT, MRI. It won't show anything because it's a transient ischemic attack. There was a blockage of flow for a little bit, but then it resolved and blood flow was resumed and it was okay. So again, TIAs indicate an impending stroke. So you want to prevent the second one. This is your secondary prevention. The primary prevention is preventing the first stroke. But if they get it, now we're in secondary prevention to prevent the second one from happening. So a full-on stroke, also known as a CVA or a cerebral vascular accident. Acute neurological deficits due to its cerebral infarction, due to sudden focal interruption of cerebral blood flow. Therefore, we're going to have issues. There are two types of strokes. And within the strokes, they have obviously different subcategories, but Big category number one are the ischemic strokes, and they represent 87% of all strokes are ischemic due to a thrombus or an embolus. Okay. Hemorrhagic is the remaining part, and this is due to a rupture of an artery, cerebral aneurysm, an outcropping of the vessel, it bursts in the brain, and you have a hemorrhagic stroke. So you can have thrombotic or embolic. And with regards to hemorrhagic strokes, you can have an intracerebral hemorrhage or here's your subarachnoid hemorrhage. They're all considered strokes. So again, this is another way of looking at it. Your hemorrhagic strokes can either be intracerebral or subarachnoid. Within the ischemic strokes, we have thrombosis. The thrombosis is normally going to be in the large arteries, so your carotids. As you start working your way up, they get smaller and smaller, but the bigger arteries can have thrombosis, or your small penetrating arteries can have blockages as well. Your embolic strokes. What's an embolism? Yeah, it's a clot, but what's special about it? So is a thrombus. It dislodged. It travels somewhere. The most common one, heart, okay, from atrial fibrillation. They get a clot formation. The thrombus is in the left atrial appendage, but the emboli breaks free, goes up, and gets lodged usually in that middle cerebral artery. Systemic hypotension is here at the bottom. This is your global ischemia. There's no blood supply going to bigger parts of the brain, so they have issues. Epidemiology regarding strokes, 5th most common cause of death in the United States. Most common disabling neural disorder. Most common type of stroke is an ischemic thrombotic stroke, is the most common type, almost 800,000 a year. 20% of stroke patients will die within the first 30 days. So management, timely management, again, time is brain, very, very important. 90% of survivors will have some residual deficits, weakness or loss of function on one side of their body, sensory problems, but they're going to have some residual deficits there. And 30% are permanently incapacitated. These are usually going to be your hemorrhagic strokes. They're a lot worse prognosis than an ischemic stroke. So patho, again, just cerebral ischemia, and whether it's global, meaning hypotension, meaning the whole brain is having issues, or is it focal, where you have one artery, one vessel that's been occluded, and anything downstream of that in the brain is now affected. That's a focal problem. But if you ever passed out due to hypotension, orthostatic hypotension, you get dizzy, lightheaded, and you fall on the ground, that's global ischemia. Okay, there's no blood supply to the brain because of gravity, and you fall down to reset everything. With focal ischemia, you have that central zone of cell death. Then you have that area around it of that ischemic zone, and that's the tissue you're trying to preserve. Again, potentially reversible. The infarction occurs where there's thrombus formation. Obviously, there's embolic material from heart is the big one. Hypertension is a big problem when it comes to strokes as well. And it usually involves these smaller vessels, and they're called lacunar infarcts. So if you ever hear lacunar infarcts, it's due to high blood pressure, uncontrolled high blood pressure. One of the other big problems you have with these CVAs is cerebral edema. You can't even see the ventricles here on this picture. Okay, there's so much swelling in the brain going on. Everything gets compressed. You can get some neurological problems just from that. And obviously look at that brain tissue, how swollen and edematous that brain tissue looks from all the cerebral edema from the CVA. And the reason they have a high death rate is because of this cerebral edema. Risk factors for strokes. Number one, arterial hypertension. We will go over that so many times. Hypertension, we know all the issues with that. Increasing age. Smoking increases risk by 50%. Diabetes, 300%. increased risk of stroke. AFib, 500%. So we're going to talk about the CHAD score again. Bring that back, the CHADS 2 VASC score. Preceding TIAs, 25% of patients that have a TIA will have some adverse event within 90 days. So you can't just disregard, oh, a TIA, okay, you're feeling better, you can go home now. No, you got to really work them up because you don't want them to have that massive stroke or they will have sort of deficits going on permanently later on. Some differential diagnoses that can mimic a stroke. So some differentials. Migraines can do it. Seizures, they don't present with weakness like you would with a stroke, but they may have what's called post-ictal confusion. Post-ictal just means after the seizure. Syncope, someone passes out. You may think they're having a stroke, but you do your assessment. No, they're fine, they just passed out. Transient global amnesia, memory disturbance, but no other neural problems. They're just forgetful, they forget things. Total global amnesia. Peripheral nerve disorders. They're also going to have weakness and radiculopathy, but you have a reason for that. They're not having a pure-on stroke. The issue that they're having is due to the peripheral neuropathies. Neuroses, panic, anxiety. In severe cases, they can mimic stroke-like symptoms. And here's your metabolic disorders. Hypoglycemia is the biggest one. So any patient coming in confused, altered mental status, you have to get a glucose on them. If their glucose is in the 20s, give them some glucose, bring it back up. Do they respond? Do they perk back up again? It's just due to hypoglycemia. So characteristics of strokes. If it's an embolus, it's going to be an abrupt onset with rapid improvement. Okay, it's a clot that broke free, just got lodged in an artery, and those are just small little things, and then sometimes they just dissolve on their own, or blood can get past it, and it's okay. A thrombus, so now we have the thrombus is building up. Think about the carotids. You have thrombus in the carotids. What do you listen for in the carotids if you think they have it? Bruits, because it's turbulent flow, because they have blockages there. And those blockages get too much, it'll start to impinge blood flow, causing ischemia. So it's going to be an abrupt onset with progression to maximal deficit over minutes to hours. So this is where onset during sleep. I say you have to know what was our last normal. That's usually due to a thrombus formation. Intracerebral bleeds, they're going to have severe headaches or alterations in consciousness. So that worst headache of my life, subarachnoid hemorrhage. They're having too much blood in areas that there should not be volume of liquid there, causing issues. So how do they improve versus deterioration? An embolus, rapid improvement. Thrombus, gradual improvement over days to weeks. And intracerebral hemorrhages, rapid deterioration over a period of a few hours. So they go down very, very fast with these hemorrhages. So here's just a review again of the blood supply going to the brain. We'll go through this in a lot more detail. Remember all the different territories, anterior, middle, and posterior. So let's go through types of strokes. So the first one we're going to talk about is ischemic stroke. And we're going to break it down by territories of blood supply. So we're going to talk about anterior circulation strokes, and then later on we'll talk about posterior circulation strokes. So basically it's the anterior part of the brain versus blood supply to the posterior part. So the first one with anterior circulation strokes are large artery infarcts. We'll talk about carotid artery occlusion, anterior and your middle cerebral arteries. So the anterior circulation includes our internal carotid artery. So we know that a lot of plaques form at the bifurcations. So there's bifurcations, and here's some as well. So that's where plaques can form, these atherosclerotic plaques. We've already gone through all that, how it forms. Remember, shear forces rip apart the vessels and cause accumulation of stuff. So, causes infarct from embolization at the bifurcation or complete occlusion of the internal carotid artery. So the symptoms they're going to have: transient monoocular blindness, monoocular, one eye. Do you think they're going to have the blindness on the side of the occlusion or the opposite side? This is the side of the occlusion. I'm sorry. Yes, side of the occlusion. It'll be the same side. Slurred speech they may have, some aphasia, contralateral sensory or motor deficits. So if they have a left internal carotid occlusion, the left internal carotid feeds the left part of the brain, but the left part of the brain controls the right side of the body. So that's why you have contralateral motor problems and some sensory issues as well. Carotid artery occlusion causes cortical function loss. In the dominant hemisphere, you're going to have issues with language. So if they have problems with speech, it's their dominant hemisphere. Remember, how do you know what their dominant hemisphere is? What hand they write with, it's the opposite side of the brain. If they have symptoms of neglect or confusion, it's a non-dominant hemisphere stroke. This is how you localize where these strokes occurred. Gaze deviation will occur toward the infarcted hemisphere. So if they have any issue with their eyes, it'll be gazing towards the affected side. They may also have hemiparesis, hemisensory loss, lethargy, stupor from the carotid artery occlusion. So, characteristics of carotid artery syndrome: ipsilateral monocular vision loss, that amaurosis fugax. Okay, it's the same side as the occlusion. Feel like a shade has come over their eye. Episodic contralateral arm, leg, whatever, weakness. Contralateral side. Slurred speech, aphasia, ipsilateral headache as well. Carotid bruit may be present where that bifurcation is. That's why you listen for bruits. They may have ipsilateral microemboli or hemorrhages. Exudates may be noted in the ipsilateral retina. So when you do your eye exam, you may see some changes there as well. That's the carotid artery. Again, the bigger vessel going up. Now we're going to get smaller as we go to the anterior cerebral circulation. Also maybe due to an emboli or subarachnoid hemorrhage with this anterior circulation infarction. Symptoms. This is the anterior cerebral artery, and that controls your lower limb. So they have lower limb problems because it's the anterior cerebral artery that feeds that part of the precentral gyrus, that motor cortex. Sensory loss, apraxia, inability to complete a motor task. It won't work because the muscles aren't working due to the stroke that the patient had. So symptoms are going to have contralateral paralysis, more so than the leg, greater than the arm. They may have some arm involvement, but the leg will be worse with a true anterior cerebral artery infarction. Contralateral sensory loss, again, leg is worse. Apraxic gait. Contralateral grasp reflex and sucking reflex. Sucking reflex is a primitive reflex. We'll talk about this when people go through different parts of dementia, end-stage dementia. They go back to their primitive reflexes, sucking and grasping. Okay, those are the two primitive reflexes. All babies know how to do that when they're born. They're pre-made for that. Abulia is spontaneity is lost. Yes?
How do you have contralateral sucking? It's like
I think contralateral grasp reflex, but the sucking reflex, the sucking reflex is not contralateral, sorry. It's kind of confused the way it's written. It's only one side, yes?
Why is the paralysis worse on the leg?
Because the anterior cerebral artery feeds the legs and the lower extremities in that homunculus. Moving on to the middle cerebral artery. These are main stem occlusions that result in severe disability, contralateral motor and sensory. Homonymous hemianopsia may be a finding with this middle cerebral artery. Global aphasia if the dominant hemisphere is affected. Global aphasia, what's that? Problems with speech, you can't talk because it's on the dominant side. So cortical function loss. If it's the dominant side of their brain, aphasia, agraphia, acalcula, and alexia. Okay, if it's the non-dominant hemisphere, the middle cerebral artery on the patient's non-dominant side, they're going to have neglect, apraxia, and confusion. So neglect, that's that hemispatial neglect. They won't only groom one side of their body, they'll only wash one side of their body, they'll comb one side of their hair, the other side will look disheveled. It's hemispatial neglect due to this non-dominant middle cerebral artery occlusion. Yes?
Do they think that they do both sides, or can they see in the mirror?
They don't even, like, it doesn't, they don't recognize it. It's no, like, there's nothing there. Like, for them, like, they may see it, but it doesn't click that it's hemispatial, they just neglect half of their body. And again, here's your gaze deviation towards the infarcted hemisphere. So the eyes will gaze towards that side. Hemiparesis. Now this side is the arm is going to be weaker than the leg because this is the middle cerebral artery that feeds the face and the upper extremities. Hemisensory loss, hemianopsia again, because again, we're going to have middle cerebral artery, half of the body will be affected. Moving on to posterior circulation stroke syndromes. There are two of them here. Obviously, your posterior cerebral artery and your vertebral arteries as well. Remember, with the circulation to the brain, we have the anterior circulation, which is your carotids, and we have two arteries in the back. They're smaller, but they're called vertebral arteries, and they also feed the posterior part of the brain. And then they all communicate in that circle of Willis to kind of help with blood supply. So a posterior cerebral artery occlusion, if in the affected area is the occipital lobe, they're going to have hemianopsia, the visual cortex is going to be affected, memory problems, unformed visual hallucinations, posterior cerebral, remember that's all the visual cortex is all in the back. If you have a stroke, lack of blood supply to that area, you're going to have vision problems, seeing things that aren't really there. And there's another thing called thalamic syndrome where they have sensory loss, aphthatosis. So remember, the thalamus is the sensory relay for all sensory to get to the brain. And if the thalamus has problems, you're not going to have sensory getting through to those areas. If the infarct affects the brain stem, they'll get Weber syndrome. They get ipsilateral cranial nerve 3 palsy. Okay, what's cranial nerve 3? What's that called? Your oculomotor. Okay, so you're going to have problems with your pupils with cranial nerve 3 palsies. Hemiplegia, here's your paralysis of eye movements because your oculomotor nerve, cranial nerve 3, is now affected. And ataxia with brainstem issues. If you have a problem with your vertebro-basilar artery, binocular visual disturbances, vertigo, nausea, vomiting, tinnitus, again with your vertebro-basilar artery occlusion, sudden loss of postural tone of all 4 extremities. What's also in the back here that controls coordination of movement? Cerebellum, that gets affected as well. So you'll lose your postural, remember your cerebellum is for your postural tone, allowing you to stand up and be upright. Slurred speech, maybe some numbness, cranial neuropathy, eye movement problems, paralysis, and eventually you can also have a coma with these ones as well. So we're talking about all the different types of how they will present. So these strokes are just like MIs, and you have your 12-lead EKG and you see where the problem is, and you can localize, okay, this artery is having the problem. With neuro, it's all symptom-based, and you do your neuro exam. If you ever go to the hospital, the neurologists walk around with a little case because they need all those tools that you guys buy in PD Lab. They actually use them in neuro. Okay, everything else is just a stethoscope and you're fine. But in neuro, they need all that stuff. They need the reflex hammer, the monofilament, all that stuff. They're going to need it. This is a weird one. This is called subclavian steal syndrome. Okay? The issue with this one, we have an occlusion right there. Subclavian artery occlusive disease. So a subclavian artery right there is occluded. So where is blood not going to get to as well as it should? Which arm? Which way is this going? Left arm. So the left arm is going to have a lack of blood supply. It's going to become ischemic. So what happens is we steal blood from the vertebral arteries, and you see the arrow is pointing that way. So that vertebral artery is going to lose blood supply because we're stealing it to get to the subclavian artery to give you blood supply to your left arm. Okay, so subclavian artery branches distal to the obstruction act as collateral pathways to maintain upper limb perfusion. If the level of stenosis or occlusion is proximal to the vertebral artery, reversal of flow from that vertebral artery may present. What do you think is going to be the problem here? Where are we having lack of blood supply now? To the brain. That's why we talk about it with stroke. So not having a true stroke, the problem is in the subclavian artery having an occlusion there, and we're stealing the blood from the vertebral artery. So they're going to have signs and symptoms like syncope, pre-syncope, where they feel everything is going away from them. Some neural deficits, blood pressure differences between the arms. Arm claudication, okay? What's claudication? Cramping due to lack of blood. So your arm is going to be cramping because there's no blood there because we have a subclavian artery occlusion. So the treatment for this one is endovascular stenting. You just open up that subclavian artery, blood supply follows its normal pathway, and you stop having the subclavian steal syndrome. So that's what that is. It's not a true stroke. The problem is a subclavian artery occlusion, and we're stealing the blood from the vertebrals. Small vessel disease. Now we're dealing with those small little vessels. These are these lacunar infarcts, and again, it's always going to be with hypertension. These are not preceded by TIAs. These things develop very slowly, and it's a stepwise progression. So they'll be at this level for a while. When they have a new lacunar infarct, and that one forms, you're going to have a decrease in their ability to do things. Then they'll be at that baseline for a while. Then another lacunar infarct happens. We have another drop in function. They're there for a while. Again, if you're not treating the blood pressure, these will keep happening for these patients. And that's a stepwise progression in the disease, your deficits. So you can see here are those lacunar infarcts. They're small vessels. They just burst little hemorrhages. They clot up, and you can see these on scans as well. So assessment of our stroke patients. They're mean for you. Okay, it is a medical emergency. Strokes are medical emergencies. Remember your ABCs. Okay, airway, breathing, circulation. Now the problem is we get increased intracranial pressure because we have swelling of the brain. Remember that cerebral edema. What happens when you get cerebral edema, it decreases your respiratory drive. If our respirations go down, we get hypoventilation. With hypoventilation, what happens to our CO2 levels? They go up. But the problem is, increased CO2 causes further vasodilation of the cerebral arteries, which further makes your intracranial pressure worse. That's why cerebral edema is so bad. It makes your CO2 levels go up, which makes the cerebral edema even worse. So a big thing we have to worry about is blood pressure management with these stroke patients. Lab studies you want to get your CBC, get a SED rate, check your CMP for this one. Here's your glucose again. Remember, one of the big signs or differentials is just hypoglycemia. It's an easy fix. Check the sugars. PT, PTT. Why do we want to know those numbers, even the INR? What do they tell us? Clotting. So the higher those numbers, are they going to clot easier or harder? Harder to clot. Hypercoagulable workup for a young patients should not have clots. They should not have strokes. And if they do, get a hypercoagulable workup. You get all those factor V Leiden, all those factor S, get all those things and see, are they having any issues with clotting that can cause them to make these clots that causes them to have a stroke. Quickly reverse any condition contributing to the problem. Hypoglycemia, blood pressure issues, stuff like that. Easy fixes, those differentials, make sure you check all that first. EKG monitoring, obviously you're going to keep them on tele while they're in the hospital. Rule out any cardiogenic causes, AFib. If they do have AFib, find out, is this new onset, paroxysmal, or chronic AFib? Talk to the patient if you can. If not, talk to family members, look at their chart, see what's going on. Are they on anticoagulation if they have AFib? If they are, find out which one. Some of them have reversal agents. If they're on Coumadin, find out what was their last INR. Because part of the thing with the TPA that you want to give, you have to watch out for risk of bleeding, because what you're giving them is clot-busting drugs. If they're already anticoagulated, they can bleed out and make it even worse. Diagnostic studies. The first thing you do is always a stat non-contrast CT of the head. Okay, most important test you can do. If it's an ischemic stroke, it looks dark. Why does it look dark in an ischemic stroke? Blood is white on the imaging, right, in CT scans. And if you don't have any blood supply to a tissue, there's nothing to glow. So it looks darker than the surrounding tissues because it's ischemic. So this area up here is darker because they're having a massive ischemic infarct on that area. Now, let's look at the one below. That is a hemorrhagic stroke because the blood is now leaving the arteries, going into the interparenchymal tissue of the brain, and it glows white. That is a hemorrhagic stroke. You cannot give TPA for a hemorrhagic stroke. You're going to kill your patient. So you have to do a stat non-contrast CT to see, are they having an ischemic stroke or a hemorrhagic? If it's ischemic, then we can go on with our treatments. If it's hemorrhagic, we got to get neurosurgery involved to clip that artery to stop it, and other things. So again, when you're looking at your CTs, if it's ischemic, it's going to be darker because there's lack of blood. If it's hemorrhagic, bright white. MRIs you can do also if obviously they're more sensitive, but you're not going to do an MRI first, do a CT. If the CT doesn't really show anything, you're not really sure, get an MRI done and it'll give you a better answer. Because acute infarct with MRI is seen sooner than CT. And also MRIs are very good for brainstem and cerebellar strokes as well. So MRIs are more sensitive, but CTs are faster. You get a CT in 10-15 minutes. History and physical for your patient, obviously most important. When was their last normal? Check for hypoglycemia, seizures, syncope, migraines. Again, these are mimicking strokes. Rule those out first. Physical exam, check your carotid bruits, peripheral pulses, and obviously you're looking for signs of atrial fibrillation. Your vascular screening, carotid Dopplers, very good for carotid artery stenosis. Transcranial Doppler ultrasound. This is looking at intracranial, internal carotid artery, middle cerebral, or your basilar arteries. You can get a transcranial Doppler to see blood flow through those vessels. The MRA, okay, angiography, we put contrast dye and we see how the arteries are doing in the brain itself. The big thing are these aneurysms or other vascular lesions. Are going to have any issues with that stuff. So the conventional angiography is the gold standard for arterial venous malformation or subarachnoid hemorrhage. However, there is a risk of causing a stroke during the procedure. Even during a cardiac cath, when you blow up the balloon, you're at risk for causing a stroke in those patients if that clot breaks free. So there's always a risk of stroke whenever you do an angiography, especially when you suspect they have blockages and buildup of plaques. Other things, your transthoracic, obviously your TEE, the transesophageal echo, is better at looking for atrial thrombi. And you can do this after the acute treatment phase. You don't have to do the carotid ultrasound right off the bat or the TEE first. Wait till they resolve their symptoms or are stable. Then you can worry about looking for any clots in the thrombus. Okay, let's talk about management. How do we deal with our patients? So the only approved therapy for stroke is TPA, tissue plasminogen activator. Okay, that's it. That's the only approved therapy. So all we're going to talk about now is when do you give it and what are the contraindications and so forth. Ideally, within 3 hours of the event, sooner the better. Now, anyone who presents in time to be a candidate must be evaluated by a physician within 10 minutes of arrival. Okay, Neuro now has like these little robots with an iPad. They do FaceTime, and they'll go into the emergency room and they'll evaluate the patient over the teleconference, and they'll see the deficits in their body, and they'll rule, okay, they're having a stroke, yes, give TPA and so forth. They got to get a CT scan within 25 minutes, and that CT must be interpreted within 20 minutes of test completion. Because again, time is brain, we have to act fast. Let's get these things read. It's called a wet read usually, and they'll look at it really fast to see what's going on. And ideally, IV TPA less than 60 minutes after they get to the ED. So once they get in, you got an hour. Try and get it in there as much as possible. Patients presenting with stroke onset who are not candidates for TPA, aspirin, once you know they don't have a hemorrhagic stroke. Okay, it's once hemorrhagic stroke's been ruled out, but they've had these symptoms for 6 hours, we can't give TPA, you give aspirin. Antiplatelet therapy for the arteries. So here is the contraindications. You cannot give TPA if they have any of these conditions when they present to the ED. Most of them just make common sense. When you go through these things, just use common sense, just think about it. Would I want to give someone blood thinners if they've had these things recently? Head trauma, prior stroke, previous 3 months. Risk of bleeding more. Symptoms suggestive of any type of hemorrhage, you can't give TPA. We know that already. Know it. If you have a hemorrhage, they're going to bleed out everywhere. If they've had an arterial puncture at a non-compressible site, if you get an arterial stick in your arm, they're going to put a compress on you. If you get a cardiac cath and they go through the groin, they put a compress on you. But if you've had arterial due to a car accident or something, within 7 days, that wound may not have healed properly, and by giving TPA, blood may leak out of that and cause more problems. Any previous intracranial hemorrhages, if they have a neoplasm, arterial venous malformation, or any type of aneurysm, you can't give them TPA because they're at risk of bursting that aneurysm, and now they bled out everywhere. Any recent intracranial or intraspinal surgery, you can't give TPA. Again, recent surgeries are the big ones. Think about it that way. Blood pressure over 185, diastolic over 110, you can't give TPA for those patients. Active internal bleeding. Makes sense, they're already bleeding, you're not going to want to make it worse. Acute bleeding, diathesis, but not limited to, that's not even there. Platelet count less than 100,000. They're at risk for not being able to clot eventually, and that cause more problems. Any type of heparin within 48 hours. INR greater than 1.7. Can't give TPA. What can you do? Let's say you really had to give a patient TPA and their INR was 2. What do you give to, what's the antidote for Coumadin?
Red
vitamin K. You can give them vitamin K ahead of time, drop it down, and then give TPA. Any of those direct thrombin inhibitors or direct factor XA, all those like Xarelto, those type of drugs, you gotta be careful with those. Blood glucose less than 50, you wanna make sure that that comes back up before you give them. Make sure that that isn't the cause of their stroke. And if they have a multi-lobar infarction, multiple lobes are affected, be careful giving TPA. You can't do it with those patients. These are relative exclusion criterias where they may get TPA depending on the condition. Only minor or quickly improving strokes, they clear automatically. Indicative of maybe a TIA. You don't really need to give TPA for that, but you could. Pregnancy, be very careful. I would not give TPA unless OB signed off on it. Anyone coming in the ER, they're pregnant, obviously you gotta be very careful. There's a big fight. OBs won't see a patient unless they're 20 weeks and above. Otherwise, it goes to internal medicine and you gotta deal with it. So 20 weeks is usually that cutoff. Seizures, major surgery or trauma within 14 days, recent GI or urinary tract hemorrhage within 3 weeks, or acute MI within 3 months. Why the acute MI? What do they give you during an acute MI? Well, they load you up with Plavix and they give you usually like a Pixaban or something like that, which is again a clot busting drug. So if they've already had it in their system for 3 months ago, find out how much they were given, were they having any complications with all that before you give them TPA now. So blood pressure control with ischemic strokes is very important. We have an occlusion and blood supply getting past that is hard. We have an occlusion that's going to make, so you need a higher pressure to get through that ischemic area. So it's very dependent, blood flow in those distal vessels, dependent upon systemic blood pressure. The elevated BP may be a chronic condition or just due to decreased cerebral perfusion. So, guidelines recommend that BP not be treated in an ischemic stroke unless systolic is over 220 and diastolic is over 120. You don't need to treat the blood pressure. They need that pressure to get past the occlusion. If you drop their pressure too much, there's no pressure to get past that and you make the ischemic zone around that infarction worse. So you have to keep that pressure up. If it is higher than 220 over 120, you give labetalol. IV in this case. The goal, lower BP by 15% in the first 24 hours. So it's a gradual reduction in blood pressure. Again, if lowered too fast, you worsen the perfusion. You make the stroke worse. So you have to keep that blood pressure a little bit higher than normal, than you would want. So after the acute event, they've come in, they've had their stroke, whether or not you treat them with TPA or not, the acute event is over, they've stabilized, this is either their new normal or whatever. Obviously, prophylaxis for DVT and PEs because they're going to be immobile. They may not be able to walk for a while. They've had the right lower extremity is down. Okay, so they're going to be bedridden. You have to watch out for clots. You don't want to cause clots to form, and then you have a lot more problems with PEs. PT, speech therapy, OT, swallow studies. So we mentioned before that all the little cranial nerves are all involved in swallowing. Any stroke patient has to be NPO until you see how they can swallow. So bedside swallow studies are done by nurses or different techs, and they have different varying thicknesses of fluids. And they see at what point do they start having issues with swallowing. They start choking. Start like water, then like honey and different things, syrup and whatnot. The different consistencies and viscosities to see how they can swallow to make sure that they can swallow everything without coughing or choking. Because what are you at risk of doing if they have that? Aspiration pneumonia. So you got to make sure they're NPO until they pass those swallow studies. Again, if they survive the acute period, a little over half will regain independent function. 30% will remain incapacitated and require long-term care. So one of your jobs is to figure out where this patient going to go. You can't just say discharge. You got to say, where are they going? Are they going to a sniff? Are they going to an ALF? If they're going home, make sure they have a support system. Where's their bed located? If it's on the second floor or the first floor. Can they go upstairs or not? Are there things in their hallways that are tripping hazards? Okay, loose rugs, they walk and they can trip over them. So these are things you have to be looking out for, and you'll get through this a lot more with geriatrics. So that's really much it for strokes. Again, the only treatment is TPA. Go through those contraindications of when should you never give TPA, but that is really the only treatment for strokes. That's easy to remember. That's it. For TIAs, they're different from strokes because they have complete resolution of all those focal deficits within a short time, minutes to hours. It's a transient, okay, it's not permanent ischemic attack. But it is a warning sign of a future massive stroke. Don't disregard TIAs. They will precede thrombotic strokes in 50 to 75% of patients. So if they have a TIA, the risk goes up. And it's hard to identify the area of thrombosis because it is transient. When it's a focal neurological deficit that's constant, you can figure out, okay, they're having right arm problems. We know it's got to be their left middle cerebral artery. But if it goes away, you really don't know where the problem is. So if you suspect a TIA, again, it's an urgent eval. Determine the type of location of the TIA if you can. Always non-contrast CT of the brain. Ultrasounds, MRIs, MRAs to demonstrate circulation, evaluate for any stenosis, okay, in those circulations. Check your TEE, EKG. Hospitalization may expedite workup, so you can put them in like a 23-hour observation, and you can get everything done while they're in the hospital, and then it makes it easy. Consider hospitalization. So who should be hospitalized with a TIA and actually be admitted, not just for observation? First TIA in the past 24 to 48 hours. If the symptoms are worsening or last more than an hour, keep them admitted. Neuro ICU, follow them there. If they have known carotid artery stenosis, AFib, or that hypercoagulable state, get them admitted to the hospital. Don't let them leave, because they could be throwing more clot. This way, they're in the hospital. They're going to have neuro checks every 2 hours. Nurses will see if there's any issues going on, and they'll call you. TIA treatment, you can consider thrombolytic therapy for TPA if it's residual and it sticks around for a longer period of time. Antiplatelet therapy is the most common thing you're going to do. Aspirin 325. You don't give them the baby aspirin, you got to give them 325. And there are other ones, Ticlid, Plavix. They're very expensive though. The other thing too, Ticlid is a BID dose. So it's twice a day. So your patients have to take it twice a day. Patients are non-compliant. Once a day dosing is easier for patients. So aspirin once a day. Plavix is now generic. It's cheaper. You can give Plavix. But again, these are both aspirin or antiplatelet therapies. These are arterial issues, not venous issues or slow-moving blood. The other thing you can do is a carotid endarterectomy. So you ever see a patient that has a thin line on their neck like this? That's usually the carotid endarterectomy. They pretty much open up the artery, clean it out, and close it back up again. So that's what that is. ABCD rule for TIA. Who is at risk for a full stroke in a week? So you count them up. Age, 60 years or older, you get a point. BP, okay, elevated BP, you get a point. Clinical factors, unilateral weakness, one side of the body, gets 2 points for that one. Speech disturbance without weakness, only is 1 point. The duration, again, greater than 60 minutes is 2 points, less than 60 is only 1. So scoring, If they have very low points, very low risk, but just know that when they get to the 6 or 7 points, now you're up over 10% of those patients are at risk of a full stroke in a week. Okay. Okay, so take a break. Come back at 11. Okay, let's finish up. We only have like 18 more slides to go. Don't forget, you guys have peds after endo. I did tell Professor Green to come early just in case Professor Nair finishes up early. She'll start earlier as well. So now let's talk about primary and secondary prevention. We want to prevent these strokes from happening. These are your risk factors. We want to prevent the first stroke from happening. Blood pressure reduction, your cardiac risk factors, so smoking is a big one. If they are at risk for stroke, are they on aspirin? Yes, they must be on aspirin. You want to prevent that thrombus from forming. The thrombus forms and gets bigger due to platelet aggregation and all that fun stuff we learned last year. Anticoagulation if they have AFib. Anticoagulation reduction, 70% reduction just by putting them on anticoagulants to prevent that clot from forming. Remember with AFib, the blood pools in that left atrial appendage. It doesn't move, therefore it clots. So by giving anticoagulation prevents the clotting from happening. Antiplatelets prevent platelet aggregation and making a clot or thrombus that way. Hyperlipidemia, control that, 20 to 30% risk reduction in the setting of coronary artery disease. If they have asymptomatic carotid stenosis, watch for that, 50% reduction in strokes when you do that. So again, these are all things just to prevent that first stroke from happening. We know they're at risk for stroke with hypertension. We know the risk goes up with smoking, diabetes, AFib. We want to prevent that first stroke. Secondary prevention of stroke and TIA. So they've already had that first stroke or they had that first TIA. We want to prevent the major one or that second one, which could be severely debilitating or potentially kill that patient. Stroke survivors average 10 outpatient visits a year. So they're going to be coming to the doctor's office a lot afterwards. If they had an embolic event and they had AFib, they've got to be anticoagulated, especially after that first one. Non-fatal stroke reduction by about 20% in patients with TIA or minor stroke. Just give them aspirin. Okay, you can give aspirin, give Plavix as well. If they have 70% or more stenosis in the carotid arteries, same thing you learned with Dr. Ovalle, 70% or more, you can do a carotid endarterectomy. Again, we want to prevent that second stroke. They come in, they have their first one, you do a carotid Doppler as part of your workup, and they've got severe carotid artery stenosis. That's the culprit, you treat it, you take care of it. Lipid lowering therapies, those statins, make sure they get on all those cholesterol levels controlled. And obviously the big one, stop smoking if they do smoke, and your other cardiac risk factors, diabetes, weight, all that fun stuff. Here's your AFib. 20% of all strokes are just due to AFib. And if you look, we have a straight path. Let me change the color. All the way up. Internal carotid. We go up, and then there's that middle cerebral artery is where they mainly go a lot of the times. All patients should be on anticoagulants. Once they're able to, especially if they got TPA, you may have to wait before you start them on anticoagulants, but they will at some point have to go on anticoagulants. Warfarin versus aspirin. Is warfarin more effective than aspirin in preventing strokes for patients with atrial fibrillation? What they did, they had this randomized control trial. One group got aspirin 75, and the other one was given warfarin to maintain an INR between 2 and 3. The warfarin with an INR of 2 to 3 was more effective than aspirin in preventing strokes without increasing the risk of bleeding complications. That's the problem with Coumadin. You can bleed very easily with that. You have to be tightly controlled and monitored to make sure you don't go too high, well above 3, and so forth. The rate of stroke in the warfarin group was 1.6, but the aspirin was 3.4. So the warfarin was better at preventing strokes. But again, 20% of all strokes are from AFib. So maybe that was a confounding part of that one. Here's your CHADS VAS score again. CHF, hypertension, age, diabetes, previous stroke, 2 points for that. So again, should they be on anticoagulation or not? So as you get higher in this CHADS VAS score, then you need to go to the warfarin. If they have a low CHADS 2 VAS score, you can keep them on aspirin. But as that risk keeps going up, the higher the CHADS VAS score, they need to be on anticoagulation, warfarin, Coumadin, rather than just aspirin. Okay, now we move on to hemorrhagic strokes finally. Now we've gone through all the ischemic ones. Let's go through the hemorrhagic. You start bleeding out. So the first one, intracerebral hemorrhage. Hypertension is the most common underlying cause for these problems. Chronic hypertension disrupts the autoregulation. We went over that. Remember, the brain likes a constant blood flow, and high blood pressure will alter that autoregulation. Promotes structural changes in the walls of the penetrating arteries. Again, may cause bleeding, which is what we're worried about. We don't want a hemorrhagic stroke. Bleeding sites, where do they normally happen? Deep cerebral area, so putamen and the thalamus. The lobar, subcortical areas are big areas where hemorrhagic strokes can occur. And your pons and also the cerebellar areas as well. So again, CT, look at all the white. Okay, because we have a hemorrhagic stroke, blood is leaving the vessels, going into the intraparenchymal or intracerebral space, causing issues. Subarachnoid hemorrhages are usually due to ruptured cerebral artery aneurysms or arteriovenous malformations. So they're usually an aneurysm, AVM, but again, we have a weak wall. When you have a weak area, when it gets under stress, they can break. That's the first, like the weakest link. And they break, and then you have a hemorrhagic stroke. Bleeding will cause increased intracranial pressure, giving you a headache, and decreases cerebral blood flow, and that may cause you to have loss of consciousness. So signs and symptoms, worst headache of my life. Why? Because they're bleeding in their brain, the brain is swelling, and going against that skull, it can't expand, so you start getting really, really, really bad headaches. They may have loss of consciousness, headache, neck stiffness, non-focal neuro exam. There's really nothing wrong anywhere else, but just really, really, really bad headache. So here's your AVM, a communicating vessel between the arteries and the veins. It should not be there, but it makes a weak part. Less than 1% of the population has them. Cause is unclear. Most of it is going to be congenital, so you're born with these things. Obviously, you'll never know that you have them until something happens. You don't go looking for these things normally. And once found, you treat it with clipping. And I think I have a drawing for that later on. Here's your intracerebral hemorrhage. Again, non-contrast CT as always. You never give contrast at first because if they have a hemorrhagic stroke, all that contrast dye is now leaking out of the vessels and affecting the brain tissue directly. So you'll see obviously bright white, whether it's in the brain itself or outside the brain parenchyma. And you can also get an MRI if you really want to look at it and see where those issues are coming from. But non-contrast CT should show most of it. So a patient with a presumed subarachnoid hemorrhage. Coming in, worst headache of my life. You do a CT and it shows hemorrhaging. You think they have a subarachnoid hemorrhage. So if at first, that non-contrast CT is negative, but they're really complaining of a really, really bad headache. You suspect they have a subarachnoid, but the CT doesn't show anything yet. Get an LP done, lumbar puncture. So maintain a high index of suspicion and a low threshold for performing a lumbar puncture. So if you suspect they have a subarachnoid hemorrhage, just very low threshold, just get a lumbar puncture done. See what the CSF shows. They're going to have what's called xanthochromia. Okay, so it'll be slightly tinged pink because there's red blood cells now, because there's blood in the CSF. It's a subarachnoid hemorrhage. That's where the CSF is located. Blood is leaking into the CSF now, and you'll see it on a lumbar puncture within 4 hours from the time of the hemorrhage. So we talked about BP control in the ischemic patient. They need a higher pressure to perfuse the tissue beyond the thrombus. If you lower the pressure too much, it makes the ischemia worse. But now we have a hemorrhagic stroke. So the higher the pressure, the more blood is going to be pouring out of that tear in the vessel. So we do have to be a little bit more cautious with our blood pressure management with a hemorrhagic stroke. So when you're studying these things, again, these are part of the treatments, make sure you understand what blood pressure, 220 over 120 for an ischemic. For a hemorrhagic stroke, the goal for systolic, 140 to 60, 140. So if their blood pressure is 150 to 220, you need to lower that down to 140 to 160 range. You want to reduce the perfusion going into those leaky areas because you're just going to make it worse. You can't apply compression because it's the brain and the skull's there. So we have to figure out, let's lower the pressure for those patients. Drugs that you can do for that, continuous IV infusion, nicardipine, clofidipine, here's your labetalol again, and your esmolol. Those are the types of drugs that you can give for BP lowering via IV for these patients. In a subarachnoid hemorrhage, still again, keep it below 160. Optimal BP is unclear. Here's your labetalol again. Just remember labetalol. You don't want to give nitroprusside or nitroglycerin. Why? They're vasodilators. They're going to make the bleeding worse. So don't give them those. Yes, well, vasodilators, the nitroglycerin and all those things, will they lower your blood pressure? Yes. But the risk of the dilation of the vessel will make the bleeding worse. So avoid those ones. Just remember labetalol is the big one. You can give them for both ischemic and hemorrhagic strokes to lower the pressure. So you have to be careful with lowering blood pressure too much. It's a little game, a little dance you got to play. So if you lower it too much, may be offset by an increased risk of infarction because now you're lowering the blood in that area, may cause more ischemia in those tissues. So what we do is we look at what's called the cerebral perfusion pressure, which is the mean arterial pressure minus the intracranial pressure. So therefore, with an increased intracranial pressure, your cerebral perfusion pressure may be impaired. Increases in MAP may be the only way to perfuse a patient. So always watch for that mean arterial blood pressure. What's a normal mean arterial blood pressure? 65, like in the 60s. Remember, it's a combination of your systolic and your diastolic. That whole formula gives you that mean arterial pressure, about 65 millimeters of mercury. ICP is measured via a catheter, so they're obviously going to be in the ICU to see what the intracranial pressure is to give you more. This is more ICU management. If you work in the ICU, then you will be doing this more often. If you don't, the neuro will take care of all this stuff for you. Further management. So if they have elevated intracranial pressure, keep the head of the bed elevated. Gravity will help and pull that blood out of the head. Keep it going down. If you bring them Trendelenburg, where their head is below the feet, blood's going to go into the brain. We don't want that. We want to reduce the pressure, make sure they're upright. You can also consider sedation. Okay, give them a medically induced coma. That will also help reduce intracranial pressure. You can consider mannitol for that. Hyperventilation. What's that going to do? So remember, CO2, if we blow it off, we have lower CO2, causes vasodilation, therefore reducing intracranial pressure. The opposite happened before we talked about with the ischemic strokes. So that's where that comes in. Watch for seizures and obviously control your glucose as well. Surgical intervention. You need to stop that bleeding. It's not going to stop on its own. You have a damaged artery wall. It's exposed. Blood will continue to ooze out of that. So you can do what's called surgical clipping or a placement of a coil for an aneurysm. And I'll show you what that looks like in a second. Another thing you can do is what's called external ventricular drainage, or an EVD. If they have a risk for hydrocephalus, which with a subarachnoid hemorrhage they could because all that blood's going in that area, you just drain off the excess CSF fluid, and that helps reduce the intracranial pressure. You can ligate or embolize the AVM as well. I'll draw that in a second. Open craniotomy. Take the skull out, look for the bleeding, and then you can clip it externally, or you can do it internally through interventional neurosurgery. Are they even a candidate for surgical options? So you have to assess your patient. Depends on their level of consciousness and what kind of neural deficits they have. Grade 1, normal level of consciousness. They're in their bed, they're sitting up, they can talk to you. There's no issues there. They have some mild symptoms. Yes, they are a good candidate for surgery. Grade 3, they're a little bit confused. They do have a focal neural deficit. Their right arm is down, paresthesias, something focal that's causing issues. Yes, they are still a candidate. But when are they not? They're in a coma, and there's your decerebrate posturing. What is decerebrate posturing? Arms are out. Remember I told you that's a bad prognosis. When they're decorticate, it's better. Decerebrate, no. So if they're in a coma and their body is fixed in this position, they are not a candidate for surgery. They can't go for surgery. So they get no surgery for those patients. So coiling. So we have, let's say we have an aneurysm right there. Coiling, the neurosurgeon will come in and they will put a bunch of wire into that area. Oops, oh, that deleted. Okay, put all that stuff in there. Eventually, it's going to endothelialize. Vessel will come over, and now we've isolated that aneurysm, and we're not going to be at risk for that bursting anymore. The other thing they can do is clipping. So we have, again, there's our aneurysm. They will come with a surgical clip, and they will just clip it. And that causes a wall, essentially, but it breaks away the aneurysm, so it's not going to be affected anymore and risk of rupturing. So that is what a clipping is. And you'll see these on imaging because they are metal, and you'll see them on CT. You can't do MRIs with these patients anymore because they have surgical clips, and they're metal. That's what clipping is, that's what coiling is. Different ways to get rid of these aneurysms. Mortality with these hemorrhagic strokes. High levels of mortality. 20% of these patients will die even before reaching the hospital with a hemorrhagic stroke. 25% die from the hemorrhage or complications. 20% die from rebleeding of these hemorrhagic strokes. So very, very, very high mortality rate with these intracerebral hemorrhages. And there you go. I'll see you guys next week. We'll do dementia and stuff like that. Yes. Uh-huh.